Good evening, sir.
Good evening, Mahapatra sir. Welcome. Srinivasan sir, welcome. Sir, Srinivasan sir, you are muted.
Audible?
You are audible, no issue.
Audible?
Yes, sir, you are audible. Let everybody join, sir. Okay.
Hello.
Hello. Beta, you try sharing the screen and see. Share the screen and see.
Hello.
Share the screen, no? We'll see. PPT. You open the PPT and share the screen.
Your dress ನೋಡ್ರಿ ಗ್ರೀನ್ ಇದೆ ಚೆನ್ನಾಗಿ.
Hello.
Hello, you need to share the screen. You are not shared the screen.
Am I audible, sir?
You are audible, but share the screen. Sirijan, you open the PPT in your laptop. Who is there from DIAP? Who is there from DIAP?
Hello.
We are hearing you, but can you share the screen?
Yes, sir. I'm sharing screen.
Once the screen is running finely, then fine. Make it full screen and run some slides. Run the second slide. No, 1 second. Go back to the first slide. Okay. Fine. Now you stop sharing. No issues. You are audible and it's fine. Okay.
Good evening, sir.
Good evening. Good evening. He is able to share it. That's fine for us. No issue.
Good evening. Good evening.
Good evening, sir. Bhupendra.
Srinivasan sir, good evening. Good evening, Mahapatra sir.
Yes, sir.
How are you? Good to see.
How are you, sir, Upendra, sir?
Absolutely fine. Coming to your
Upendra,
city
hi.
next month. Hi, Subbu. How are you?
Yeah.
Ramakrishna sir has not yet joined.
Yeah, he's yet to join. Let him join. No issue.
3-4 minutes. 9 o'clock, there is an ICP meeting.
Okay, go. No issues.
Yeah.
You can just have one word and then.
Yes, certainly. Sir, September is going to be a quiet month, full of academics. Then October, everything will start. Different picture. IIP will have in a different color.
Upendra, everything is needed in IFP. There should be
Yes.
complete masala.
Good evening, Paramahamsa sir.
Ramakrishna Garu, you have to unmute.
Good evening, Upendra ji. Good evening.
So last Wednesday I was in the train.
Yeah. Good evening, Subbu.
Good evening. Good evening.
Ramakrishna Param, sir.
Good evening, sir.
VP sir has joined.
Yeah, Biswajit is there. No issue.
Sir, good evening, sir.
Current
good evening,
VP,
sir.
past
Biswajit, how are you?
VP, everybody is there. And current VP, past VP, and future VP, all are there.
Okay, thank
And
you. Thank you, sir.
And VVIP, Dr. Srinivasan sir.
Yes. Now Srinivasan sir is thinking, when should I become VP?
No, he is VVIP.
Oh.
Ramakrishna, sir.
Right, sir. Right.
आज का TOT बहुत अच्छे हो गए विश्वजीत.
Sir, बहुत बढ़िया हुआ, sir. Excellent, sir. I just left at around 5:20-25. I think we had ended almost at that last.
Actually,
Yes.
you are covering all practical points. There's something good.
विश्वजीत
yes.
जल्दी से भुवनेश्वर ब्लॉक कर दो एक.
हाँ सर कर देंगे ना. जरूर सर. जरूर. Tomorrow again it is there at 3 o'clock.
Yeah.
So everyone is requested to be there.
No, it's very good. I think, Dr. Upendra ji, you may give some more importance to IV fluid management.
IV
That's
fluids,
what I
I'll
was
just
telling,
check
right?
if we
Because
can.
that is day in and day out. Right.
Correct.
Right.
And people just give hypotonic fluids most of the times. Yeah.
That's what. See, very large number of people do it wrongly.
Isolate P for everybody.
For everything, isolate P. Habits die hard. That's the
Yes.
problem.
Shall we
But
start?
sir,
Yes.
I think in Pal's course, IV fluids is very well taught, sir. I am one of the
No,
faculty.
that is there, sir,
Those
but
who
this has
attend
wider
Pal's course-
reach. This has wider reach and physical.
Yes. Those who attend Pal's course, I think they cannot go wrong with IV fluids.
No, that is there, but very few people undergo PALS, Dr. Vishwajit.
I think let's start.
Yes,
Dr.
yes.
Vishwajit added
Okay.
value today. Now may I request our National President, Dr. Upendra Kinja Vadekar, who graced this post-grad teaching activity, despite his very busy schedule. I invite Dr. Upendra Kinja Vadekar to give us some inspiring comments, opening comments.
Yeah, very good evening, friends. Thank you so much, Dr. Ramakrishna sir, for those appreciative remarks. My dear friends, the teacher of teachers, Dr. Srinivasan sir, Dr. Subramania, Dr. Ramakrishna, our VP, East Zone, Dr. Biswajit Mishra, and of course, the team members, Dr. Bala Subramaniam sir, Dr. Sara Dhanavade madam, Dr. Sanjeev Rawat, Dr. Tushar Baniar. Some of them are not logged in today. Probably they will be joining us soon. So today, we have this yet another fascinating series of PG Reach, which we have started under the Diamond Jubilee different academic programs. One of them was for postgraduates. And it's really making waves across the country. And we want to help all our PG students across the country as much IIP can do, whether they're appearing for DCH, MD or DNB. Everybody needs to have one practical, some inputs. And today we have a child with breathlessness. And I'm really very happy to welcome Dr. Sabnarendra Mahapatra, sir, Professor and HOD from AIMS Bhubaneswar, and Dr. Srijan, welcome you, young boy, who would be presenting a case. And I'm sure with Subbu around and a respiratory case, what more you want? So apart from Dr. Mahapatra sir and of course Dr. Srinivasan, Dr. Biswajit, Dr. Ramakrishna, students are going to have great learning experience how to go about it, because in the end, it's diagnosis does not matter. It is your approach that matters as far as your exams are concerned. And I'm sure you are going to get all those valuable tips. I would have loved to listen to the entire conversation, but I have committed for another meeting which has already started at 9 o'clock. So thank you so much. And PGs, please keep spreading the word amongst your colleagues across the country. And request to all HODs who have logged in to ask your students to be there. Thank you so much and happy
Just a
learning
minute,
to all
sir.
of
Just
us.
a minute. Just a minute. Just a minute. Dear PGs, Dr. Upendra Kinjavadekar has arranged again, give another chance for all of you to have the personal individual mails. You do contact either of your heads of the department or any pediatrician. You will get the Google form. You fill it and send it. From now on, you will get it into your inbox, your personal email with the link. Right. Thanks, Dr. Upendra, for doing this. Thank you.
Thank you. Thank you, sir. Thank you.
Dr. Subbu, Dr. Subramanya. Right.
No. I think all that I have to tell is thank you, Upendra,
Yeah.
for patronizing this program. And we will not waste much time. And congratulations to the young boy and the team guided by Dr. Mahapatra, sir. And we will straight away start with the case presentation.
Right.
Good evening, everyone. Today we are presenting the case of a child who is presented with breathlessness. So, R,
I think you are not audible.
hello,
You may come a little closer.
Ah,
Right.
hello,
Yes, now
hello.
you speak up.
R, a 10-month-old boy infant, presented with the chief complaints of cough for 3 days, fever for 3 days, and fast breathing for 1 day. Audible, sir.
Yes, better.
The presenting complaints were the child presented with cough, which was wet type, insidious in onset, which gradually progressed but did not have any diurnal or postural variation, and no aggravating or relieving factors noticed by the parents. It was accompanied by high-grade continuous fever, which was responding to antipyretics, but there was no other history of any other focal fever. No crying and picturation, no history of alteration of sensorium, and child was febrile when he came to us. Over the last 1 day, the child had history of fast breathing, which was insidious in onset and had gradually increased. And the child was on presentation irritable and unable to take feeds as per parents. The child had history of admission to hospital for similar episodes of fever associated with fast breathing 3 times over the last 5 months. Presently, the child is of 10 months of age. And the mother on probing gave history of forehead sweating and suck rest suck cycle while the child took feeds. But there was no history of any cyanosis or bluish discoloration noticed by the parents. There was no history of any choking while feeding, no history of any rashes over skin, no history of any ear discharge, no history of any respiratory distress immediately following birth, no history of any large bulky stool or salty kiss which was noticed by parents. But parents gave history of poor weight gain as per noticed by parents. And the
But Srijan, just hold on. Can you go back to the previous slides? Previous. Right. So 10 months young infant complained with cough, cold, fever, and fast breathing. Yes, carry on. The next slide. Next one. See, there is wet sounding cough. Okay. And you would have asked for any associated audible sounds. Younger the baby, more likely the cough may be associated with audible sounds. Secondly, whether rhinorrhea is associated, that cold is associated. Why I am asking for these things?
The upper respiratory tract involvement as well, sir.
No, audible sounds need not be upper respiratory.
Audible
alone.
sounds can be stridor, sir, can be wheeze, sir.
No, stridor is too much. You may say wheeze. Okay, stridor. Anyway, they would have complained it. You need not elicit it. Okay. And regarding fever, what else you would like to ask? The history of present illness is one where you would like to elicit the causative agent for this fever and cough, whether it is viral or bacterial. What else you should have asked?
Whether the child is
Related to fever and cough.
whether the child is active in between the afebrile, when he is afebrile or not. If it is viral etiology, he will be active in the afebrile period. If it is bacterial, he will be toxic and sick looking all the time.
Next.
Then, sir, whether it is responding, not whether there is a similar history in family members or not.
That is contact in the family.
Suggest
of viral if it is there. What else?
And sir, the course of the illness, whether it is slowly progressing or it is fulminant, that can give an etiology, sir. Whether
it started with high grade because most likely it may be viral. What else you will ask? You will ask whether there is entire respiratory tract is involved or only part of it.
Yes, sir.
Or any other system is also involved.
Yes,
which is
sir.
suggestive of viral. Whether it is associated with any body pain, crying during fever episode. Okay. That would have given us some more information about the etiology. Right. Once there is cough, once there is localization to a particular symptom, you may not ask for burning micturition. Okay. When there is no focus, we are more focused on it. Urinary tract infection, because it's obvious there is cough, there is fast breathing. Most likely it is unrelated to urinary tract system. And again, in fast breathing, you would have asked for any associated audible sounds, right? And what does irritability tell us?
Irritability, sir, the severity of the respiratory distress, whether the child is able to take feed, because if he is not able to take feed, that is an indication of admission along with respiratory distress. Sir.
No.
Irritability can be because of hypoxia as well, sir.
Right. Instead of saying unable to take feeds, you would have better mentioned about his ability to take breast milk, ability to suck at the breast.
Yes.
Okay. Because this baby being an infant. Okay. Next. Right. Forehead sweating is suggestive of, you will be knowing it, but for the benefit of average postgraduate who is attending.
Yes. It is more suggestive of cardiac etiology.
Suck rest suck cycle again related to it is what actually, why it actually occurs. Suck rest suck cycle. What does it indicate?
Due to exertion, sir. The child cannot
In a
exert.
small baby, you cannot make them to walk or do some exercise or climb the stairs. You cannot. That's why the simple sucking at the breast itself is an exercise. That means the baby is not able to perform the routine activity because of this breathlessness. You did not mention cyanosis because already bluish discoloration you have mentioned and no technical terms. Okay.
Yes.
Right. Next. Again, rash over the skin, if it is present, it is suggestive of
some viral etiology possibly.
Next.
Yeah. Can I come in, sir?
Yeah, very much, sir.
Yes, sir.
You go back to the first slide, beta. Yeah. I will just give you 3 or 4 scenarios for you. Suppose cough starts first and then the fever and fast breathing. What is your diagnosis? Suppose fever starts first and then cough and fast breathing. What is your diagnosis? Suppose fast breathing starts first and then there is cough and fever. What is your diagnosis? So can you tell me all the permutations and combinations?
That's Subramania is asking DM questions. Okay.
No, not DM, sir. It is
No,
simple. Which one is the first one to start? Which is the first one to start?
Sir, if
All are
cough is followed by fever and fever, cough followed by fast breathing, it is suggestive of more of pneumonia, sir. If child initially having fever and cough and
okay, you should not say pneumonia.
no,
You should use the word parenchymal disease.
parenchymal disease.
Lung parenchymal.
See, it is suggestive of parenchymal disease.
Yes.
Lung parenchymal disease. We don't know whether it's pneumonia or non-pneumonia. Fine, fair enough.
Yes.
At this stage. Suppose the fever was first and then there is cough and fast breathing. What does that mean?
So if fever was first followed by cough and fast breathing, it is suggestive of more of a viral etiology, sir. can be more of
Not
an
necessarily.
upper respiratory.
Okay, good. But the fever can be either upper respiratory
Upper
or
respiratory.
lower respiratory.
Or lower respiratory.
Either upper respiratory or lower respiratory. We'll never know. Correct? No. Okay. Let us say fast breathing comes first and then there is cough and fever.
There can be in this age of child, sir, can be a foreign body as well, sir. If there is.
Excellent point. So I think the only, just wanted to have an open mind and think. And if the fever and cough is there and there is a rapid fast breathing in the very first day,
Yes.
I mean, in the second day versus the rapid breathing happens on the third day, like here. For example, fever happened and 2 days later fast breathing happened versus mild fever and cough was there and very next day fast breathing happened. What are the two DDs that you would think?
Rapid progression can be in bronchiolitis, sir, whereas
Excellent.
be more of a prolonged
So
progression.
this is evolved over days and hours and therefore it
Yes.
can be pneumonia. So very simple. So therefore, at least we are able to fairly conclude that there is a parenchymal involvement, probably community acquired pneumonia at this stage. Correct? No.
Yes.
Now, what are the symptoms that are strikingly absent in this child at this stage? Cyanosis is absent. Okay. Then wheezing is absent.
Yes.
Now you tell me respiratory only. What are the things that are absent?
Respiratory absent symptoms are, sir, any respiratory, no atypical sounds are heard. No
Correct.
sudden worsening of symptoms is there. And
Correct.
for etiology of child has had multiple admissions. So in favor of that
So
multiple.
therefore, that we will not go into detail. At this stage, can I just conclude by telling that there is absence of upper respiratory symptoms?
Yes, sir. No,
Well, that is a fairly good thing. Okay. Second is, can I also go further and tell you that there is a relative less of airway symptoms, especially proximal airway?
yes, sir. No history of any
Okay.
sounds.
Yes. Now, this is exactly what I wanted from you. Localize it to lower airway disease because of fever and cough. I will say that it is probably a parenchymal disease. Now, fair enough. Now, I think you got it right. Right. Now, after this, you are now trying to say if there is some kind of suppressed cycle and therefore cardiac. Now, can you tell me now, is this a cardiac case or is it pneumonia? Now, I'm confusing you.
Sir, if history
Or
of
both.
the history of suppressed cycle and forehead sweating are more towards cardiac case, but fever and respiratory distress have precipitated it. So it can be super added infection on a cardiac person. Respiratory was precipitating the
Which respiratory diseases can have exertional dyspnea?
interstitial lung diseases can have, sir.
Can have exertional dyspnea. Can this be interstitial lung disease?
Can be, sir, because there is history of poor weight gain is there, but any signs more than symptoms, the typical history wise is not eligible, which is more seen in this.
Okay. See, you can say predominant cough, fever, etc., more than the breathlessness to
Yes.
start with, will put us down as far as interstitial lung is concerned. Okay. Now, therefore, do you think this is a significant amount of involvement, or mild, moderate, or a severe respiratory disease?
Severe, sir, because it is causing irritability, hypoxemia, as suggested, and unable to take feeds as well. So as of
As
now,
well. So, okay. Now, there is only one hint I want to give regarding feeding.
yes.
Reluctance to feed, poor feeding in respiratory versus poor feeding in cardiac. Can you compare the two and tell me? Feeding history in cardiac, feeding history in respiratory.
Feeding history in cardiac, sir, there will be typical forehead sweating and suppressed cycle will be present. Whereas in respiratory cases, sir, the child will have tachypnea associated with it, sir. If he is having vigorously feeding and having tachypnea along with it, which might not
Correct. And there will be history of sometimes choking.
be. Yes, sir, which is not there.
That history should ask. Second, what else? What other history you get? Usually, poor feeding comes in the early part of respiratory disease or in the last part of respiratory disease.
Later part, sir.
Later part. In cardiac, can it come early or late? It can come even early.
It can be from the start, sir.
Isn't it? It can start with the feeding difficulty itself. So
Yes.
this is small difference, subtle difference between a cardiac versus respiratory that I wanted all the postgraduates, including you, to understand. Mahapatra, sir, you want to add something? You can add it.
Regarding history of present illness, Professor Mahapatra.
Okay, sir. Fine.
Right. Carry on. Move on.
There was no history of ear discharge, any respiratory distress immediately following birth. No notice the large bulky stools or salty kiss by parents, and but history of poor weight gain they are giving as per the parents.
Why you
So
are
this
asking
being a
that?
recurrent respiratory symptoms, you have asked for some history of ear discharge. Which
Yeah.
recurrent respiratory disease will have history of ear discharge? Tell me.
Primary ciliary dyskinesia can
Why,
present.
why?
Because the cilia will not be functional, sir. That will impair the drainage from the eustachian tube. It can cause recurrent.
Correct. So therefore, they will have ear discharge. So recurrent ear discharge, often not just one time, isn't it? So that is a feature. Sinopulmonary and ear discharge. Respiratory distress immediately following birth, which disease?
It can be congenital causes that can cause immediately following birth, sir.
Which are the ones?
Uh, can be in neonatal periods, sir, can present with surfactant deficiencies can present like, sir. Other than that, sir, any preterm, if the child was preterm, that can cause hyaline membrane disease can present like, sir.
Okay. Can you tell me day 1 respiratory distress, day 2 respiratory distress, day 3 respiratory distress, day 7 respiratory distress, day 30 respiratory distress?
Depends on the sir, whether the child is
You
term.
tell me common. 1 or 2 in each.
It is a term child, sir. It can be transient tachypnea of newborn, sir. It is
Okay.
a term child. It can be hyaline membrane disease, sir.
Both of them don't carry forward. Okay. Next,
Yes.
day 3.
Day 2, day 3 of life, it can be a cardiac cause which is presenting on day 2 or day 3 of life, sir.
Reason,
Okay.
reason why on day 2, day 3 for cardiac causes?
So mostly when the PDA closes, yes, reason.
Yes, sir.
That is the period during
Okay.
which doctor is likely to close.
Yes.
Physiological.
Imitating and presenting on day 2, day 3, sir.
Okay. What else?
Any
Can
other?
be congenital pneumonia, sepsis,
Yes, sir. They can also present, sir.
possible, isn't it? Okay. Next. Can this also be PCD? Sometimes they present with
Yes, they can present. PCD can also
with
be there.
early neonatal period, respiratory distress also. In first 2 or 3 or 4 days of life also, you can get respiratory distress. 1 month later means you can have that BPD and all that. Okay. Chronic lung disease of newborn. You can think of them. Okay, fine. Now you go ahead.
There is significant past history, sir, that the child was admitted at 5 months, 7 months, and 9 months of life for similar illnesses, which required hospital stay and oxygen support and IV antibiotics as per parent, but child was never mechanically ventilated, according to parents. So the child had used to have 4 to 5 days of stay and was discharged as following treatment.
Now, at this stage, before going to respiratory, you think predominantly it's probably a cardiac case, correct? Right
Yes.
now. Okay. If a cardiac case is there and the first admission is at 5 months,
Yes, sir.
what are the diagnosis that comes to your mind?
Can be a ventricular
You-
septic defect, sir, presenting first at around 6 months of age, sir, because they typically present around 6 to 7 months of age. Sir.
6 months or 6 weeks?
After
6
6
months.
weeks. After 6
6
weeks.
weeks.
6 weeks, isn't it?
Yes.
So therefore, so if you say any shunt, but probably a VSD, correct?
Yes.
Number one, number 2.
Can be PDS, sir, presenting.
Okay, number 3.
Sir, as per age of the child, sir, there's no history of cyanotic, so acyanotic heart disease only are more. So, positive, sir.
Okay, you can think of any left to right shunt. The
Yes.
question is the shunt mild, moderate, or large shunt?
Depending on the age of presentation, sir. If it is
Now
presenting
is the age of presentation, you know now here 5 months.
5 months, 6 months, sir, it is more likely to be a moderate size shunt, sir, because if it is a
Excellent,
large size, it
doesn't it?
is presented earlier. Sir.
Moderately sized shunt. We don't know, we will know by examination, correct? Now, any other history that you would like to ask at this stage itself?
History of
What was the type of admissions at 5th month, 7th month, and 9th month? How long was the illness?
Yes, sir. Now the duration of the illness, sir, in the course of hospital stay.
Okay.
Whether they required any oxygen or mechanical ventilation, any escalation of respiratory support, and the typical time of resolution of the
So
symptom.
what was the information here?
According to them, sir, the child only required IV antibiotics and oxygen support by nasal prongs or mask they were able to see, but never required mechanical ventilation.
So therefore, the child was having frequent flooding and therefore probably wet lungs and infection. That's fine. That's exactly what you are trying to tell. Correct? No,
Yes.
it looks like a left to right shunt.
Yes.
Now, I would like to invite Dr. Ramakrishna, sir. Sir, you think it is a pure, simple, uncomplicated left to right shunt, or it could be a complex congenital heart disease?
Unlikely. Complex is a little unlikely, but large size, moderate to large size VSD. Can
So
be.
at this stage, we will not think of any complex
Right.
congenital heart disease. Fine. Now, I think one more question I would like to know is, are you interested in knowing the position of the child while it feeds? Like will the mother predominantly feeds left side of the breast, right side of the breast, whether predominantly child lies to feed while lying down, or doesn't, I mean, is it comfortable in some kind of posture? Do you want to ask these questions?
Respiratory distress in a certain position can indicate laryngomalacia, but
Very good.
so whether the child is having problems while in prone position or is comfortable while in supine position and is comfortable in prone position, that can tell about whether it is laryngomalacia or not. So,
Very good. Very good. Excellent. Please go ahead.
Dr. Srijan,
yes.
when you are thinking in terms of underlying cardiac abnormality, you should have asked what is the status of the infant in between the escalation of the symptoms. If it were to be purely respiratory, the baby is most likely to be near normal in between the episodes. If it were to be cardiac, likely that the baby will have some difficulty. Maybe suck rest cycle may not be in full-blown picture, and forehead sweating may be some, it may be there. So in between how the baby, you may try to ascertain. Okay. And you can ask for the progression also, how the difficulty at sucking is at the age of 5 months and 9 months. That tells whether there is some worsening in the cardiac status. Right? You are doing good job. Move on.
Family history wise, sir, he was a first birth order baby born out of a non-consanguineous marriage with no similar family history, no history of sibling death, and no documented history of TB contact as well, sir. Birth history prior to birth, mother did not have any history of fever with rash or X-ray exposure, no history of diabetes or hypertension as per mother. Antenatal scans were reported to be normal and she perceived fetal movements as per at 5 months, sir. And on birth, at full-term child, born by normal vaginal delivery, 2.75 kg, and cried immediately at birth, and according to mother, breastfed within the same hour and discharged on the same day. With uneventful postnatal course, no hyperbilirubinemia, respiratory distress, or an ICU stay documented.
Single X-ray exposure may not cause any problems. Don't say that exposure to radiation. You better put it as radiation.
Okay.
Single exposure to one X-ray is not going to matter much. Okay, right. Carry on.
But developmental history as per prior to the illness, according to the parents, the child had attained milestones as per 9 months of age. So he was able to sit without support, occasionally standing with support, immature grasp. Stranger anxiety, according to parents, was there and could speak bisyllables. As at the time of admission, this could not be assessed as the child was in distress, but as per history, sir, they were giving that he was developmentally appropriate as per history. And immunization also, they have vaccination card that he was immunized till 9 months of age with disease scar present.
No,
He was
which schedule? You mentioned which schedule? Is it
According to the national
national immunization schedule for our states. And, he was on mother's milk and complementary feeding had been initiated at 7 months of life with appropriate protein intake and calorie deficit of 19% and belong to upper lower class as per modified Kupuswamy scale.
yes?
So,
carry on.
and on general appearance, the
1 minute,
No,
sir.
before going to general appearance,
Ramkrishna,
anything else? Anything else?
Ramkrishna, sir.
Yes, sir.
And also Mahapatra, sir, you are in All India Institute of Medical Sciences.
Yes, sir.
I just wanted to know how relevant is Kupuswamy classification for economic status?
No.
It's more of complex thing rather than
Yes, sir.
making things clearer.
No, sir. No. I'm just, this is a food for thought, maybe for postgraduates. Let us follow that. I'm not criticizing, but I wanted to tell you a lot of changes do happen. But we are sticking to the upper, middle, over, etc.
Yes, sir.
But I think the health facilities have taken a different type of shape in the modern years. With due regards to the type of classification, I think the main reason was in those days, was the burden of malnutrition as a social disease and as an economic disease that were looked upon. But till date, it is relevant. But I think maybe, sir, from Premier Institute like yours, you can take up the issue and revise the whole thing for the current context. This is my earnest request.
Yes.
I mean, don't take me otherwise, sir.
No,
Please.
no.
Yeah, please go ahead.
Dr. Srijan, before going to general appearance, why don't you complete anthropometry?
It is there after the general appearance and vital.
First, after immediately, better I think anthropometry.
Okay.
See, after that vital data, then general examination, head to examination, you narrow down to the systemic examination, gradually narrowing down to it. Okay.
So, sir, basically what we are following here, first we have just general appearance. After that, we take the vitals. If the vitals are stable, then we are taking the anthropometry, detailed anthropometry. Then
Okay, sir. Please.
cardinals.
Okay. Please proceed better.
Yes, sir. As per anthropometry, sir, observed and expected, he had moderate stunting, moderately underweight, and moderate malnutrition. But head circumference was normal as per WHO both charts.
So what's your inference?
Inference that this child had a long-standing illness, sir, because moderate stunting was also observed, sir. It was not an acute event. It was not an acute cause of malnutrition. It was a long-standing issue, sir. Because weight was also on the lower side and height length was also on the lower side, sir.
What was the birth weight?
2.7 kg, sir.
Okay.
Just a minute. We'll go back, right? You would have told us another derived anthropometric parameter.
Yes, sir. Weight for height, sir.
Length. Okay.
Weight for length, sir, but below between -1 to -2 standard deviations for the child.
Right. The baby is a stunted, underweight, and wasted.
Yes.
Okay. Right. What could be the cause in your view?
What could be the cause?
Cause, sir, if it is a cardiac cause, sir, it requires more effort from the side of the child, sir, and even with appropriate feeding, it can cause long-term, sir, malnutrition, chronic.
This parameter faltering can be because of multiple factors.
Yes.
It need not be undernutrition as the name suggests. That is to be again redefined sometime later. Undernutrition means only underfeeding. Here, primary cause is underlying disease. Is undernutrition contributing or not in this baby?
Can contribute, sir, because the child
can. Suppose this baby is around, say, a toddler. What else will tell you whether there is some contribution of undernutrition?
Recurrent infections, sir. The child will have recurrent respiratory tract infections. Malnutrition.
What else? What other parameter will help you to know whether undernutrition is contributory? Underfeeding, we will put it that way.
Poor weight gain and poor height gain will be there, sir, as per age.
No. See, I'm asking contribution of underfeeding apart from chronic disease. Okay, skin fold thickness contribute, and mid-upper arm circumference also.
Yes,
it is nothing much to do with chronic disease. It is more related to skin fold thickness and upper arm, mid-upper arm circumference, more to do with underfeeding and so-called undernutrition. Okay, and you would have better depicted in a growth chart.
Yes, sir.
I know this is the first time they would have come to you, but when they are coming to you time and again, that will be very much useful. But otherwise also, if you show and depict in growth chart, the message will be clear. Okay. Move on.
Then general examination, so the child was sick looking with respiratory distress and was moderately built and poor to moderate nourishment was there, sir. But the child was conscious and alert, but he was irritable at that time, sir, when he presented to us.
Dr. Srijan, the days of saying moderately built and moderate nourished are over.
Yes, sir.
When we were PGs, there is nothing like anthropometric parameters, nothing like growth charts. Then it is a rough estimate of the built and nourishment. Yes. Now that there are so many parameters, better not mention built and nourishment, especially in an infant. Okay. You have finer modalities of assessing the nourishment and growth. Isn't it? That sick looking is because of
Sick looking is because of sir, respiratory distress, sir. Respiratory distress and the child was febrile when he presented to us at that time.
Sick look is different. When the child is having respiratory distress, is more of restlessness
Yes,
rather
sir.
than sick looking. Sick
Yes.
looking may tell you that maybe the respiratory infection is of some bacterial origin.
Yes, sir.
See, when it is viral, the child will not look sick, but he will be having distress.
Yes.
Right. When you say conscious and alert, you want to say the infant doesn't have,
Altered sensorium or that
he
time.
doesn't have
Hypo-
hypoxia.
hypoxia. Yes.
Right. That message you wanted to convey. Right. Next. Good. Carry on.
On vitals, sir, the heart rate was 166 beats per minute. All central peripheral pulses were well felt, and it was as per age. It was the child had tachycardia, but no radial or radiofemoral delay was appreciable. And respiratory rate was 72 with use of accessory muscles of inspiration. Abdominothoracic type respiration with nasal flaring, suprasternal intercostal retractions, along with intermittent subcostal recessions were also noticed. And he had a temperature of 98.2 degrees in the right axilla, and saturation was recorded around 89% in room well, which improved to 96% with oxygen support by nasal prongs around 2%.
Just hold on. See, don't say HR. You don't count the heart rate. We would like to count the pulse.
Yes.
So put it as pulse. When it is very difficult, you may count heart rate. Okay. Otherwise, its head should be pulse,
Yes.
rate, volume, rhythm, volume, and delays. Okay.
All self.
Now that it is 166, I understand it's very difficult to count. But
Yes.
anyway, put the heading of pulse. Then you may say that because of difficulty. Otherwise, the message goes wrong, isn't it? In this baby, with this much of tachycardia, I understand it's very difficult. Even
Yes.
assessment of volume is also important, but still you make a mention of it.
Okay.
Right.
On head-to-toe examination.
And you would have mentioned about CRT also.
Yes.
Did you mention? No. That also you mentioned.
Pulses were well fit.
Because he has significant respiratory
Yes.
infection or distress. CRT also better you mention it.
Yes.
Right.
On head-to-toe examination, sir, pallor was appreciable, but no icterus cyanosis, clubbing, lymphadenopathy or edema, and no neurokeratinase markers or overt signs of vitamin or mineral or micronutrient deficiencies were there on examination. Sir.
I'm unhappy to interrupt you time and again,
Yes,
but
sir.
unless if we keep silent, that amounts to endorsing, right? It doesn't mean that by telling it is not other way around. Okay. Whenever there is pallor, you always try to ascertain the cause of pallor. Where else you will do it if not here? You don't have any separate system for it.
Yes.
We have only cardiovascular, respiratory, CNS, and GIT. That's all. So we would like to know what's the cause for pallor. That has some bearing on the treatment, isn't it?
Yes. Chronic
How do you ascertain the cause?
chronic undernutrition can be there, sir. We can take
No.
nutritional
Like
history.
pallor. What caused pallor?
The pallor can be there due to undernutrition or due to increased
Okay, I understand, Srijan. It is nutritional.
Yes.
Out of nutritional, what it is? Is it iron deficiency or macrocytic? And how to know?
If it is a chronic iron deficiency anemia, sir, there might be the history of poor feeding on the mother side. It can cause, sir. And for
No. Say we are in the examination, not in the history. What else you will examine to ascertain the cause for pallor?
sir, we can examine any nail changes are there or not. But in this small child, it would be
I understand it, but generally I'm asking not exactly about your friend. So look at the nails,
Nails,
look at the tongue, whether it is bald, loss of papillae there, and knuckle pigmentation. Not
Yes.
exactly in your friend. In any child, you generally try to ascertain the cause for pallor.
yes.
Right. And anyway,
And particularly, so intentionally, we have not, Susan have not mentioned about the JVP. Ideally, in all the cardiac cases, I know JVP should be included. But here it is a 10-month-old child, short neck. Really, it is difficult to.
yes,
No.
sir. Yes, sir.
This is one of the comments.
Very much.
Sir, for my learning, Ramkrishna sir and Mahapatra sir, both of you can respond. These changes which we say, nail changes, knuckle pigmentation, etc., will they be present as young as 10 months or?
No.
is it in-
I told it is not for this boy.
No, not for this case, but generally, sir, how long this will take? Roughly 3-4 years?
Yes, 2 years.
Yes.
By
Around
second.
2 years. Okay.
Right.
2 years.
Right. Dr. Srijan, where do you expect edema to be present in your friend?
Sir, pedal edema can present, sir, if it is a
No,
sign,
no,
less likely.
no, it's 9 months, isn't it, infant?
Less likely, sir, very less
No,
likely.
not likely,
Yes, sir. Then,
unlikely.
if any other cause of edema is there, sir, in hypoproteinemia can cause edema.
No, here, where do, in your friend, that means this patient, where do you expect the edema to be present?
It can be in external signs and be less, sir. Internal pulmonary edema can be present, sir. But
See,
That-
you're not getting my point. In a toddler who starts walking or a child, there will be pedal edema
yes, sir.
connected to underlying heart disease.
Yes, sir.
In this baby, where do you expect the edema to be present? We cannot inspect the pulmonary edema.
Yes, sir. Sacral
Then-
edema can be there, sir.
Sacral edema.
Sacral edema can be there. It was a
Sacral
dependent parts.
and where else?
Dependent parts, sir, on the back of the head.
Sacral and over the face also.
Yes, sir. Yes. Dependent.
Isn't it? So face primarily, also over the sacrum. Okay, right. We will move on.
So as per the history, I would like to first examine the cardiovascular system, sir. And, on inspections around cardiovascular system examination, the child had tachycardia, but the child had tachypnea, but no visible precordial bulge could be appreciated, and apex impulse was not appreciable, sir, more of due to the tachypnea, sir. But on palpation, there was a
Just hold on, please hold on. See, you cannot make the inspection so sharp.
yes, sir.
The examination shall start from the neck.
Yes, sir. That I have
PGIT from the oral cavity, respiratory
Yes,
system from nose, cardiovascular system from neck at least.
Yes, sir. JVP, sir.
You may talk about nasal flare in the respiratory system,
Yes, sir.
but neck you have to examine.
Yes.
I understand assessing JVP are very difficult in your phase. You can appreciate pulsations in the neck.
Yes.
They can be suprasternal, right?
Epigastric.
There can be pulsations, isn't it? And there can be pulsations in the epigastric area,
Yes.
right? Pulsations over the back, pulsations in the second intercostal space,
Yes.
pulsations in the left parasternal area.
Yes.
You look for the pulsations in all these areas, right? And secondly, bulge is one thing, it takes some time. You can talk about any parasternal lift also,
Yes. Sir.
isn't it? You have to mention, by that we will be knowing, right, what causes parasternal lift,
It
so-called.
can- ventricular hypertrophy can cause it.
You tell us which ventricle.
Right-sided right ventricular hypertrophy can cause more of
It
this.
is only right ventricular hypertrophy here that causes the lift. All these things you better enlighten us. Okay. And physical examination should be comprehensive.
Yes.
Okay. That should be there. See, why I am interrupting you is you may cause a little bit of unhappiness for you, but hundreds of your colleagues are watching. Otherwise, the message may not go correctly. Okay, not to intervene frequently, right? Right. What about you? You have seen you saw the child. Were
Yes.
there any pulsations in the neck?
No, sir. As of at the time of examination, the pulsations could not be appreciated.
At the time of admission?
Examination, yes, sir. No
Admission,
pulsations. Yes.
there were no pulsations, is it, in the neck?
No neck pulsations or any other pulsations.
No epigastric pulsations. Epigastric pulsations are due to?
It can be due to any hypertrophy, sir. Less more likely, or due to
Which hypertrophy? Which hypertrophy?
can be due to wide pulse pressure as well, sir.
No, just a minute. Which hypertrophy causes epigastric pulsations?
Right ventricular hypertrophy only can present, sir. More of, sir.
Right ventricular hypertrophy results in epigastric. There are other causes, but in this boy, it is maybe if they are present, it is right ventricular. Left, second intercostal space pulsations may be due to?
Left atrial hypertrophy can cause it, sir. Left.
No, don't say atrial hypertrophy. They rarely go into hypertrophy.
Ventricular hypertrophy, so left.
Oh, see, you are near the base of the heart.
Yes.
Left second intercostal space. It's very important.
Yes.
Observing the pulsations in the left second intercostal space more than anywhere else.
Yes.
If there are pulsations in the second left intercostal space, they are suggestive of what is the underlying structure there?
Pulmonary valves.
Pulmonary?
Pulmonary valves.
Sorry, pulmonary?
Left intercostal, second intercostal, pulmonary valves, sir.
Pulmonary, I'm not getting you.
Pulmonary valve, sir.
No, don't say valve. Valve will not result in pulsations.
Yes, sir. It can be due to the
Pulmonary,
PH, sir, more of.
main pulmonary arterial
Arterial hypertension.
dilatation may result in. That's a very important find. Second intercostal space observation, palpation, and auscultation gives you information about whether particular heart disease is going into complications like
PH, sir. Pulmonary
PH.
arterial hypertension.
Good. Now we will move on to palpation.
On palpation, sir, there was a thrill felt best at the left lower sternal border around the 4th to 5th intercostal space in the just left side of the sternum, but heave was not appreciable, sir, in the child, sir. Second zone.
Anything else in palpation or is over?
What, sir?
Anything else in palpation in the next slide?
Yes, sir. Second left intercostal space, sir, was palpable, sir.
Which is palpable?
Second, sir, the palpable P2, sir.
Right. See, it says palpable. P2, you don't know P2 or not, it's only inference. Sound is palpable, right? Go back. Please go back. See, always feel in all four areas.
Yes.
You look for any palpable sounds. Then feel for thrills. Palpate for thrills. Then what else? Always examine the posterior chest.
Yes.
Don't miss it, right? And no heave appreciated, right? Where else you will palpate?
Sir, we can also appreciate whether any for the apex, sir, the palpation.
You did not tell the apex position. Inspection, we understand that it is difficult in a small baby. But in palpation, you have to make out.
Yes,
I
sir.
wish to know whether there is any shift in the apex.
Shifting of apex downward or outward. Sir. This is
No.
apex.
That was not mentioned, is it? So
Okay.
try to be very systematic so that you don't miss anything. We would like to know the position of the apex.
Yes.
And I know character is, ascertaining the character is difficult because of so much of tachycardia, but you can definitely localize, we are supposed to localize.
Yes.
That tells us whether the cardiac disease has gone into decompensation,
Yes.
right? What decompensation? How do you know it?
If the apex is shifted on the toward lateral sides, it can be sign of right ventricular hypertrophy, where it is if
Please don't say hypertrophy. Hypertrophy is always concentric.
yes.
It will not result in
volume.
shift of apex. Say
Volume.
dilatation.
Volume overload.
Don't talk about pressure or volume overload. It simply say, make things simple. Dilatation of the right ventricle.
It can cause shifting toward the towards outward shifting, sir, due to
Okay.
lateral side.
Then for left ventricle,
It will be down and out, sir. It can be
Right.
also lateral and inferior shifting.
left ventricular
Left ventricular dilatation.
dilatation. So even a little older child, and if the tachycardia is not that much, you will be knowing the character of the apex also. Here you talk about volume load and pressure overload, not regarding the position. When you are position, it is dilatation, no dilatation. When you ascertain the character of the apex, you talk about pressure overload or volume overload. Okay? Done?
If it is well sustained, sir, it is more of pressure overload. If not, then
So you cannot go away without mentioning the apical position. Okay? No, it may not be very important, but do percuss. At least to exclude.
any effusion. Any effusion can be there, sir, or position of the heart.
No, at least to exclude dextrocardia.
Yes.
Very uncommon.
Ah.
If you put your both palms over on either side of the sternum in the palpation, you will be the only person to diagnose dextrocardia. All of us will be missing it. You percuss, you will be knowing which side the heart is most important. That can be done even in newborn also, isn't it? People miss it. One, Dr. Srijan will be diagnosing it. You will get the eclodes. Okay, always make it a point.
So just because the postgrad students are there, just I want to tell something why we are not interested to do percussion. Because first of all, from the percussion, basically we will get an idea regarding dextrocardia, pericardial effusion, and base of the heart and other things. it will take a lot of time. And also, suppose some thrombosis is there, then it may be dislodged. So that's why during our time, we are doing the percussion. But nowadays, percussion we are not doing. But if you are suspecting dextrocardia, definitely you have to do. And pericardial effusion, the second phase will be done.
Okay, that's another point, percussion of the second intercourse space. In a small baby, you may not be able to appreciate, but give us a message that we have to do, right? Okay.
On auscultation, sir, starting from the mitral area, the first heart sound could not be appreciated as it was drowned in a pansystolic murmur, sir. And the murmur was best localized to the tricuspid area around the left lower sternal border. It was harsh and grading around 5/6, sir. And the pulmonary area loud second heart sound was appreciable, and splitting of second heart sound with inspiration was appreciated, sir. And the murmur was best localized to the left parasternal area near the left lower sternal border, sir. With no specific radiation to any of the sides, sir.
Doctor, you want to talk to me? Nice of you. See, when first you complete the mitral area,
Yes.
S1 not well heard, whether it's drowned or something. S2, whether it is heard or not, you tell. You don't characterize. S2 in mitral and tricuspid areas. You don't characterize, but you simply say it is heard.
Yes.
Then you go to tricuspid area, you mention about sounds, whether you are hearing or not, whether the first sound is abnormal or not.
Yes.
Make it a point to mention whether you are able to appreciate because of tachycardia or otherwise crying child or anything. Otherwise, the purpose of doing systematically is lost. And when you are hearing a pansystolic murmur, harsh grade 5/6, and left tricuspid area is different, and you describe the events at left third and fourth space separately.
Yes.
Yes, sir.
For a small baby,
Yes.
it may be difficult, but we try to be systematic.
Yes.
Mitral area, tricuspid area, pulmonary area, aortic area, and
Yeah.
left third and fourth spaces.
Yes,
That
sir.
is one area. Okay, you describe separately, right? And loud second heart sound is appreciable. I understand it may be difficult to appreciate whether it is A2 or P2.
Yes.
Aortic area, I really wonder whether you will be able to appreciate the split in a small baby with pulse heart rate of 166. If you had appreciated, especially during inspiration, that is wonderful, but it's very difficult to appreciate. And when you say left parasternal area, you describe the murmur.
Yes.
You have to describe the first sound in mitral and tricuspid areas, but mention about second sound that is heard. In the base of the heart, that is aortic and pulmonary area, you say first heart sound is heard, if it is heard, and characterize the second heart sound, if possible, differentiate between A2 and P2. When you are hearing a sound predominantly, loudly, that is more likely to be
If the second heart sound, the loud P2 can be there, sir.
P2. How to know it is P2 or A2 in this baby?
Sir, in this baby, sir, it is a bit difficult, but
No, but it is
based on the
not all,
side,
very
right side or
difficult.
left side?
Wherever you are hearing the sound louder, that
it
is the area of origin of that sound.
Yes.
If you are hearing the second sound loudly in pulmonary area, it is P2.
Yes.
If you are hearing it in the aortic area, it is A2.
Yes.
No, based on the interval, it is very difficult. But by location, you can tell whether it is A2 or P2. That is the purpose of going in a systematic way. And in left parasternal area, that is third and fourth spaces, you describe the murmur instead of describing it in tricuspid area. Okay? Where else you will hear? Where else you will put the stethoscope?
To hear for a PDA, sir, we'll put it in the left infraclavicular area, sir.
Left?
Left infraclavicular area, sir.
Say, there is nothing like infraclavicular, that is in the respiratory system. Say
Ah,
second space, a
left-
little away from the
Left,
parasternal line.
left
Okay?
and second intercostal space. And,
Parasternal. Where else you will put the stethoscope?
in the third intercostal space on the left side, sir, neo-aortic area. So there also.
So
we
that you already covered. That is the area where you are hearing the murmur best. Where else?
posteriorly, sir. The
Yes, yes. Always keep your stethoscope posteriorly. Inspect, palpate, auscultate posterior chest. A murmur which is widely heard all over the anterior and posterior chest is more likely to be
PDA, sir.
uh-huh.
Can can be PDA,
Anterior posterior.
anterior and posterior PDA can be heard. So machinery
Not
like
PDA. It is VSD murmur. It is widely heard all over the chest, anteriorly and posteriorly. Where else you would like to put your stethoscope? In a grown-up child, if not in this child. Just to know it for completion's sake.
carotid, sir, we can for
Very good, very good. During palpation also, I was asking, that question got submerged in the other points. You palpate the carotids, you put your stethoscope over carotids, not in your friend, but generally make it take continue. Where else you will put your stethoscope? In this baby.
any radiation of murmur to the left axilla should also be checked. So,
No, you said there it is not radiated.
it is not
You
radiated.
said localized. Okay, right. Where else? The child is having pallor.
Yes, sir. Any venous hum can also be appreciated. sir,
Yes.
if there are-
So whether you are able to appreciate or not, you cover all the headings so that even if I miss the diagnosis, no examiner will fail me. If I do in a systematic way, trying to elicit all the signs. That is my take. Okay? Right. Not to interrupt you frequently. Done.
Respiratory system examination, sir, on the upper respiratory tract, nasal flaring was observed with the use of accessory muscles of inspiration as well, sir. Suprasternal, intercostal, subcostal recessions were seen, but trachea was observed to be central with all areas of chest having equal expansion on inspection. And no visible scars, sinuses or dilated veins were appreciated, sir.
Trachea is observed to be in normal position, not central.
Yes, sir.
Central is different, normal position is different.
Yes, slightly.
Simply say, make things make life easy, make
Yeah.
things simple.
Okay.
Say normal position. Okay? Central is different, normal is different. Okay.
Trachea was confirmed to be central, sir, with all areas expanding equally or inspiration. And apex was felt on fifth intercostal space, just 1 centimeter medial to mid-clavicular line, sir. But it was on percussion, resonant note was heard over all areas with no localized areas of dullness, sir.
No, is the apical position normal?
As
10-month-old child.
in 10-month-old child, sir, either just medial or mid to the mid-clavicular line should
No,
be
no. Is it medial?
It should be, can be lateral, sir, in this.
Not can be. There is nothing like can be.
Yes, sir. If the
In
child
an infant, what is the apical position?
just lateral to the mid-clavicular line, sir.
Lateral to mid-clavicular line. And which intercostal space?
Fourth to fifth intercostal space.
Don't say fourth to fifth, it is fourth space lateral to mid-clavicular line. As the child grows, the apex comes medial to mid-clavicular line and goes into fifth intercostal space.
Yes,
You know the reason why it has to occur like that?
due to differential growth, sir. It's basic.
Between
The diaphragm shifts a bit more down as compared to
thoracic case and heart. Thoracic case. Okay.
on percussion, resonant note got heard over all areas with no localized area of dullness, sir. And on auscultation, bilateral airway entry was equal. No wheezing was appreciated, but crepitations were present over right interscapular, and infraaxillary areas more than the left side, sir. Fine crepitations were heard, sir, more of, sir.
Okay. See, try to avoid the word bilateral air entry. The bilateral air entry, the wording is mainly for anesthesiologists. For them, if the air enters in both lungs, they are happy because the tube is in place.
Yes,
For us, it is not bilateral air entry.
yes,
We have so many areas,
yes,
right? 4 in the front, 2 in the lateral side, and 3 to 4 on the side. You try to say what you are telling in for crepitations. You tell same thing about.
yes.
There are only 3 headings in auscultation. One is breath sounds. Second is VR. Third is adventitious.
I did.
We will stick to that. There is no wording like bilateral air entry.
Yes.
Okay. See, what does unilateral crepitation say? What does bilateral crepitation say in your friend?
So the unilateral crepitations, if it is there, sir, it can be suggestive of a localized patch of pneumonia. But if
Don't say
bilateral,
patch, it is likely to be pneumonia. Right.
localized pneumonia, and if it is a bilateral, it can be due to congestive cardiac failure. So base of
Is it congestive cardiac failure?
can
No, don't use the words can. Is it or not?
if fever is there, sir, then we more suggestive of pneumonia only, sir.
No, I'll tell you. If it is on one side, it is likely to be respiratory cause, like pneumonia. If they are bilateral, likely to be due to
Superadded infection.
no. It
Viral
is fine crackles in the bases is suggestive of
failure, sir.
which failure?
Cardiac, left-sided cardiac failure. sir.
Left ventricular failure. If they are fine, left ventricular, bilateral. If it is medium to coarse, they are likely to be respiratory and they will be unilateral. When crackles are there, especially in a cardiac case, try to tell their character and their location and give your inference why they are due to. Like that. And what about breath sounds? Did you hear any abnormal breath sounds?
No, sir. Breath sounds were bronchovesicular only, sir.
Right,
No wheezing was appreciated, sir.
right. Do you think there is pneumonia or there is no pneumonia?
Sir, pneumonia, sir, more of, sir.
But I was taught in my MBBS days, bronchial breathing will be there, then you diagnose pneumonia.
Yes,
But what is the change presently to say it is pneumonia? Is bronchial breathing is a must to diagnose pneumonia? What WHO says?
no, sir. It's bronchial breathing.
What WHO says?
The WHO definitions of fast breathing along with refusal to feed is more suggestive of pneumonia. Sir.
No, what else? Fast breathing and?
Failure to feed, sir.
No, you have crackles.
Yes, sir. Crepitation. Sir.
That is sufficient to call it as pneumonia, right?
Yes.
Bronchial breathing need not be necessary. Increase in VR need not be a necessary feature.
Small child.
So by your finding, I should be knowing whether pneumonia is there or not. Okay? It is a unilateral one and pneumonia, right? If it were to be pneumonia, what pneumonia you call it?
Localized can be there, sir. Can be lower pneumonia only, sir.
Say you tell completely community acquired.
Yes.
Right. Why I want you to talk about community acquired pneumonia? As if I want my wording shall come from your mouth. It is not like that. When you say it is community acquired pneumonia, you are telling me what antibiotic you are going to use. That is the purpose of mentioning community acquired pneumonia. Okay, global pneumonia is also correct. When you say like that, I know my job is easy. What antibiotic I shall use for your friend. Okay, right.
On other system examinations or on para-abdomen examinations, the abdomen was soft and non-tender, but liver was palpable 5 centimeters below right costal margin, span of 7 centimeters. And spleen was not palpable and no evidence of fluid on percussion. On CN examinations,
No, just 1 minute, please. What do you think? What happened to the liver?
sir,
What do you call it?
hepatomegaly can be there, sir.
Hepatomegaly is present.
Yes,
Due to
right-sided cardiac failure, sir.
what is the most important sign to diagnose right ventricular failure in an infant?
Hepatomegaly will be there, sir. That is appreciable.
You tell completely. Soft, tender hepatomegaly.
Yes,
We are learning from you. That's why you shall teach us in a comprehensive way. There are hundreds of push-heads hearing you and trying to emulate you. That is the purpose of making you to speak. Do you think span is 7 centimeters and 5 centimeters palpability? Only 2 centimeters of liver is under the right rib case.
can be due to push down liver, sir. Push
Due
down
to
hyperinflation of the lungs, sir.
yes, there are 2 points operating here. One
Yes.
thing is tender congested liver and maybe pushing down of the liver. That is, we are thinking of it because only 2 centimeters is under the rib case. So that is the purpose of knowing the span of the liver also. Right. Do you expect spleen to be palpable when there is congested liver?
No, sir. If it is
No.
pushed down, it can be palpable, sir. And,
No, spleen, even if it is pushed down also, it is not palpable.
typically, it is not palpable, sir.
In congestive heart failure, can splenomegaly be there?
No, sir.
No, there can be splenic enlargement also. Why should there be enlarged liver in case of congestive heart failure? Why not enlarged kidneys?
Due to
Why enlarged liver?
Due to back pressure, so due to the right heart failure, leading to back pressure, leading to
For renal also, it is back pressure only.
more of, sir, due to the enlargement of the IVC, congestive changes in the liver, leading to hepatomegaly. Sir.
There are two reasons, explanations. One, there is congestion, as the name says. The nearest organ suffers most. When there is a traffic block, the nearest bile gets congested. Secondly, the nearest is the last vein to join the inferior vena cava is hepatic veins. That's why the brunt is borne by the liver most. Secondly, the liver can accommodate more blood because of presence of
Sir, the liver can expand into capsules.
not expansion. That is one thing.
Liver,
What kidneys don't have and what liver has to accommodate extra blood.
liver has, sir, two dual blood supplies.
Sinusides. Because of sinusides, the liver can accommodate more blood. Others are solid structures. Here, even though it is solid structure, there are sinusides which can accommodate. With the same analogy, even the spleen also can be enlarged, especially in a newborn or early infancy, not in the childhood or adolescence. Right? When there is splenomegaly, that is also suggestive of congestive heart failure.
Yes.
Right.
Just, I want,
Yes, sir. Yes, sir. I'm about to ask. I'm forgetting every time. For your comments.
yeah, another comment is that why we are interested to palpate this split.
Yes, I got your point, sir. No, he will tell, sir. He will tell.
Okay, Srijan Bolo.
Right. Splenomegaly is there. What else you will suspect?
Splenomegaly can be a sign of congenital infection, sir, or can be a sign of portal hypertension as well.
Nine. In your friend.
In our friends, sir, splenomegaly can be due to cardiac failure on right-sided
No, that was already discussed.
Infective endocarditis can be
right. That is good. That's good.
Particularly infective endocarditis, the spleen will be soft.
Yes.
Right.
And that's why this is the importance of why we will examine this spleen.
And you would have mentioned in the general examination or aptitude examination, there are no signs suggestive of infective endocarditis. By that, you are telling the examiner, I know the complications of a heart disease. It can be congestive heart failure, it can be infective endocarditis. You tell the examiner, I know all these complications are to be looked for. Okay? Right. Good. We'll go on. Move on.
So,
No, CNS is normal.
yes, CNS is normal. No motor deficits of positive movement notice. So AF open and at level, bulk tone and reflex is also normal.
Okay, fine. We don't expect also, that's why, any abnormality. Right.
So, summarizing the case, sir, a 10-month-old male infant from upper lower socioeconomic class with uneventful and non-contributory birth, development and immunization history, with no significant family history, presented fever, followed by respiratory distress, history of similar episodes in past 4 months requiring multiple hospitalizations, and positive points in the history being forehead sweating and suck cycle while feeding with poor postnatal weight gain. And on examination, he was moderately malnourished with respiratory distress noted, tachypnea and hypoxia, bilateral palpitations right more than left. And
no, you are saying bilateral, then
unilateral.
Unilateral.
Right-sided, sir.
Right.
With pansystolic murmur, best appreciated over left lower sternal border, loud P2 appreciated, and thrill over left pericardium felt along with hepatomegaly on abdomen examination, sir.
Now it is open for discussion.
Right. No, don't go for investigation. Please go back. Better, most of the examiners would like to stop at this stage. So we will go to it at the end just to say, no, how is our acumen? Okay, clinical acumen. Right. Dr. Srijan, you try to enlighten us what could be the cause for all these problems in your friend.
Yes, sir. It can be, as per the case, sir, it can be a left acyanotic heart disease with left to right shunt. Most probably a ventricular septal defect, and as per age of presentation and where pansystolic murmur is appreciated along with loud P2, it can be a moderate VSD, sir. Because if it would have been a large VSD, the murmur would have been short systolic, and the age of presentation would have been a little bit earlier. And multiple episodes requiring hospitalization are not, and Loud P2, it is against the small VSD, sir. According to this might be this probably the case of cyanotic heart disease, left to right shunt, moderate VSD, presenting with in this episode with pneumonia, sir.
What is one finding which is not going with your diagnosis of moderately severe VSD?
Sir, pansystolic murmur is usually appreciated in small to moderate VSD, sir. It is short systolic murmur due to
Okay, you go further. Pansystolic murmur, which is of grade 5.
Yes, sir. Grade
When
5.
it is grade 5, what? Forget about everything. If it is grade 5 pansystolic murmur, you are likely to think in terms of
Large.
larger. No, it's the other way around.
Pansystolic, sir. If it is pansystolic murmur of higher grade, it can be just a smaller VSD, sir.
Here, it is opposite to that of valvular lesions.
Pressure.
Valvular lesions, higher the grade of the murmur, more is the severity of the abnormality of the valves. It is inverse here. More is the grade of the murmur, smaller is the
Yes.
defect. Okay. So it is inverse here. That is one thing which is not going in favor of it being mild to severe. Sorry, moderate to severe. Right. Anything else you would like to mention? You are saying, say, congenital heart disease, cyanotic variety, left to right shunt,
With increased pulmonary.
moderate to size,
With increased.
VSD. What else you would like to tell?
With moderate malnourishment as well, sir.
No, before that.
Before that. Okay. With increased pulmonary blood flow, sir.
No, that is always there. When you say left to right shunt, when you say ESD, it is understanding that it is only increased blood flow. You need not specifically mention. What else?
I'm giving a close reason.
No, you are missing the elephants and camels.
Yes, pulmonary arterial hypertension, sir. PH.
Yes.
No
What
signs of infective endocarditis.
No, before that, you say what is there before saying what is not there.
In sinus rhythm.
No, see what abnormality wise.
Cardiac failure, sir. Signs of
Why
cardiac.
not? Always mention the one which you are going to treat. What you are going to treat is your only
Yes, sir.
congestive heart failure. You focus it. You have to mention the disease, complications of the disease,
Yes, sir.
complications of the complications, then abnormality in the other systems, then nutritional status, then any specific micronutrient deficiency.
Yes, sir.
That will complete your diagnosis. Would you like to repeat for our knowledge?
Yes, sir. I have, sir. Congenital heart disease, cyanotic, small to moderate VSD with PH in C-sapping sinus rhythm without I, with pneumonia with moderate malnutrition, sir. This might be the complete diagnosis.
So you would like to modify a little.
Uh, Pneumonia, sir.
It's a community acquired pneumonia
Community acquired.
involving which part?
Right side, sir.
Right? Don't say right sided.
Right. Right lower zone. Right,
Community acquired pneumonia involving the right
right lower lobe, sir. Can we?
lower lobe. Micronutrient deficiency in our country, you have to mention, especially when there is undernutrition.
Yes.
And would you like to modify the size of the defect?
Yes, moderate VSD only we like to say so.
Right. Don't say my small, even though we are appreciating grade 5.
Yes, sir.
You don't expect the mild VST to cause decompensation yet right from the age of 5th month.
Yes, sir.
You may hedge towards severe rather than towards mild. If you don't think it is simply moderate, you may go moderate to severe rather than mild to moderate. See,
Yes.
most of the mild VSDs are small, not mild. Small VSDs are unnoticed except by cursory examination. When you say small, I think no surgery may be required, isn't it? So forget about the grade 5 murmur, because you take the most important points, you may ignore one sign which you may not be able to correlate. Try to say at least moderate or even moderate to severe, because the decompensation started at the age of 5 months. Prior to that also would have started, which they wouldn't have noticed. Right. Such a young age, there is decompensation, there is pulmonary arterial hypertension. Definitely, it has to be
Moderate to severe.
moderate to severe. Okay. There is significant hepatomegaly, tender hepatomegaly. This of all the physical examination findings, which you think is the most important? 1, 2.
This, sir, the point suggestive of pneumonia was crepitation, sir, right-sided lower lobe, localized with left-sided lower lobe.
You are speaking like an intensivist, where you are interested in only pneumonia right now. But as an intensivist, you should be interested in, apart in addition to pneumonia, what else?
Cardiac failure, sir.
Cardiac failure. More
Yes.
than pneumonia, it is cardiac failure. Okay.
Well,
What is the
underlying
other important finding?
malnutrition, sir.
No, that is very accepted. You are a conventional pediatrician also.
Yes, sir. The pulmonary arterial hypertension.
Pulmonary arterial hypertension. See, look for pulmonary arterial hypertension
Outpatient.
in all children with congenital heart disease. Don't wait for the occurrence of decompensation. You have to catch the congenital heart disease before PAH sets in.
Yes.
That is the time where you have to go for refer the baby for
Operative intervention.
definitive treatment like operation.
Yes.
So, which is the most important sign? Suggestive of PAH.
Loud P2, sir. Yes.
Loud P2. What else suggests PAH?
Uh,
Because I want to learn from you, what are the signs of PAH?
If it is a long-standing illness or any reversal of shunt might suggest a PAH.
No, we don't go to the reversal at the age of 9 months.
Yes, sir.
Hardly we are seeing any Eisenmangers nowadays.
Yes,
Probably,
Yes,
probably Professor Mahapatra would have seen it because he is in AMS. Hardly we are seeing.
Oh, sir. In Amrita, I have seen few cases. Mostly VSD, they usually come to Amrita, to the pediatric cardiology at the age of around 15 to 20 years.
This is too early. Your friend is too young to have.
Yes,
Yes.
11 months only.
Right. One thing is loud P2. Second is pulsations in the second intercostal space. Third is
Sir, if it is a increased blood flow return, it can cause a mid-diastolic murmur as well, sir. If it is a large VSD.
see
But-
what type of PAH the baby is having.
Flow-related PAH, sir.
What is it called?
Flow, due to flow, sir.
No. There is a term for it.
Flow-related PAH.
Reversible.
Reversible.
Hyperdynamic.
Hyperdynamic. Yes, sir. Flow.
Right? We shall use the established words. What is the other type of a PAH?
Obstructive, sir.
Right, pulmonary arterial obstructive changes have occurred. So we have to catch PAH in the initial phase, that is in the hyperdynamic stage. So make it a point to examine the P2 and other signs of pulmonary arterial hypertension in all congenital heart diseases who are coming for your follow-up. That is the message. Okay. Don't wait for the CHF to occur. So what is the chamber which is not much affected in your friend?
Right atrium, sir.
Right atrium. If it were to be right atrium, why there is congestive heart failure?
Yes, sir. So in this case, sir, the left ventricle would not be that much affected, sir, because of the pressure, the blood being shunted from left to right side, sir, as on the early stages, sir.
So left ventricle also takes time to decompensate.
Yes.
Why? Why?
Because the pressure difference between the left and right ventricle is in the earlier stages, it is quite significant.
See, left ventricle has to push the blood into the aorta.
Yes.
In this case, the job of left ventricle is made easier by the presence of another outlet in the form of
Shunt.
interventricular
Yes,
septal defect.
yes.
So right ventricle is not going to fail early in case of VSD. Right. What prevents the right ventricle to fail in the initial phases, even though it is pumping large amount of blood into the pulmonary circulation? What prevents?
Sir, back pressure toward the right ventricle causing.
Okay, I'll tell you. Whenever there is contraction of the left and right ventricle, they do simultaneously. When the blood is entering from the left ventricle into the right ventricle, the right ventricle is in a phase of contraction. Yes or no?
Yes.
So it will not take the brunt of the disease. It simply acts as a conduit, and the left ventricular blood goes via the right ventricle into the pulmonary artery in the systolic phase. So right ventricle acts as a conduit initially. So it is not going to fail early. And typically, what type of hypertrophy you will see in VSD?
VSD will cause more of
Till now, I am talking about decompensated ventricles.
yes, sir.
Now I am asking about hypertrophies.
Yes, sir. Eccentric hypertrophy more of will be seen,
No,
sir.
it is only concentric. I am not talking like that. It's a biventricular hypertrophy.
Slowly,
Slowly.
slowly, sir. First right ventricle, then followed by the later phase of the
Biventricular. The
Yes.
chamber is less affected in a case of VSD is left atrium.
yes.
Large amount of blood is coming to it, but atria are lazy. They don't do much work. How the blood comes from atria to ventricles?
More of, sir, due to it does not require more of contractions. Just opening.
Okay, good. You don't say otherwise around. It
Yes.
comes down because of gravity, not because of the
Not due to
contractions
the
of the atria. So whatever high amount of blood comes into the left atrium, simply it goes into ventricle without much effort from the left atrium.
yes.
Okay, right atrium is affected. That is the reason why right atrium is affected.
Yeah, due to
Large amount of blood is not going into right atrium, but still right atrium is one of the chambers to decompensate. Why?
to increase the blood flow inlet into the right side of the heart, sir.
No.
Yes.
It is not, right atrium is not getting more blood. It is shunted away from the large quantity of blood flow.
Due to back pressure changes, sir.
See, when the compliance of the right ventricle lessens,
Yes.
the same thing occurs in the chamber proximal to it.
Yes.
That's how right atrium is affected. Okay, the chamber which is least affected is left atrium. Okay, right. So my point is always the blood entering the right ventricle goes into the pulmonary circulation while the right ventricle is in contraction. So right ventricle acts as a conduit and it goes into the pulmonary circulation. That's why right ventricle is spared from getting decompensated. But what bears the brunt of this hemodynamic process? That's why PAH set in very early in this baby. Okay, I'll tell you. The left ventricular pressure is directly conducted to the pulmonary circulation.
Yes, sir.
You got my point.
Yes, sir.
Not only the large amount of blood that is going into the pulmonary circulation, the pressure in the left ventricle is conducted to there. You got my point.
Yes.
In all other cases like ASD, it doesn't happen. Here the left ventricular pressure is high. This pressure is conducted through the right ventricle into the pulmonary artery, into the pulmonary circulation. That's why the occurrence of PAH is early in case of VSD in contrast to ASD. Okay. What do you think the QPQS can be for your friend?
More than, sir.
Roughly, we have not done any interventional studies.
Around 2:1, sir. 1.5.
Good. For our learning, you tell what is QP and QS. For
Pulmonary
some
flow,
people who may not be aware of it. Yes.
pulmonary flow divided by the systemic flow, sir.
Quantum of
Yes, sir.
pulmonary flow versus quantum of
Systemic.
flow into the systemic circulation. In which type of shunt it will be highest?
Sir, it will be more in large VSD, sir.
No. Which type of shunt? I am asking not the size and
Left to right shunt.
no. That is the shunt. Of all the three shunts, where do you expect the QPQS to be very high? Relatively.
Your sir is asking regarding ASD, VSD, and PDA.
Yes, sir. VSD, sir.
No. The paradox is it is mostly in ASD, not in VSD. When the QPQS is very high in ASD, in majority of the cases, why they are not failing?
Because of no significant pressure difference, sir.
No. The point which I have mentioned, it is occurring in the low pressure zone. It is occurring in the high pressure zone. That makes the difference. That's why even though QPQS is very high in ASD, they manifest very late. Okay? The obstructive changes are very much delayed. Okay? Right. Sir, Professor Samrendra, sir, your comments.
Okay, sir.
No, you add some points to enlighten all of us.
Here we can write QPQS ratio more than 2:1. And I want to rectify that the small to moderate, it will be moderate to severe. But for severe, the MDM is absent. In a heart rate of 160, 170, it is very difficult to appreciate the mid-diastolic murmur with respiratory distress. So I think it may be moderate to severe with a QS ratio of more than 2:1.
In the general examination, you would have mentioned about any feature suggestive of genetic or chromosomal anomalies or dysmorphism. Why
Yes.
I would like you to mention? What's
Yes.
the reason?
Syndrome.
Yes.
See, the problems don't come singly, even for anybody. Same with the congenital anomalies. Congenital anomalies are likely to be associated with some other anomaly, maybe some genetic chromosomal dysmorphism or abnormality in other systems. So we should make it a point
Yes,
to
that is the point, valid point, sir.
look in a general examination. Okay, it's not to find fault. See, many people are hearing. They may take you as a role model. That's why so much of
We all are learning, sir.
no, don't get hurt. Okay, you are doing wonderful answering and all. Okay, right. Shall we go further, sir? Right. Now, we may, for the completion's sake, we may go for now. Any differential diagnosis for this? Okay, good.
More likely to be a combination of both, sir, considering our case. But the precipitating event is definitely a respiratory cause. You have an underlying cardiac illness, sir.
Now, what I want to tell is any other shunt you would like to consider before saying that it is only VSD. That is differential diagnosis. You want to entertain any other heart disease as a differential diagnosis. That is simple.
No, sir.
Probably not, because it appears quite clear.
Yes.
Right. Next, we'll go further.
So this much, sir.
You may go run through quickly for want of time.
So we have completed, sir.
No, discussion means I thought he will be showing some slides.
No,
No, in that
So
case,
we are not-
Dr. Srijan, you are talking about diastolic murmur.
Yes.
That is due to?
Increased return to the left atrium, sir.
Don't say increase return to left atrium.
Ah.
Here, left atrium is a bispectator. That
Ah.
doesn't do any work. Just he enjoys more flow across it,
Yes.
through it. What is the cause for mid-diastolic murmur? Where the hemodynamic event occurs.
The mitral valve, sir.
Increased flow across the normal mitral valve.
Yes, mitral.
A murmur can generate because of increased flow across the normal valve or normal flow across a abnormal valve. Okay, here is the first case. What is the other finding that can occur because of the increase in the flow across the mitral valve?
Sir, again, sir.
What other hemodynamic event or sign you will appreciate because of this phenomena of increased blood flow across the mitral valve? Some other thing also you will be able to appreciate. Yes, it is third heart sound.
Yes, volume overload can cause heart, sir.
Third heart sound you may hear because of the increased flow. Right.
Yes.
I heard, I learned in my MBBS, third heart sound may be physiological. Suppose it is very difficult to hear in this case. Suppose you hear third heart sound in such children, do you take it as physiological?
No, sir.
No, sir, not in this side, sir.
It may be physiological when everything else is normal. When the heart is diseased, you cannot take it physiological. Suppose this baby has third heart sound. What do you call the
So it is a sign of volume overload, sir. Left side.
triple? What do you call it as?
Failure, sir. It is a sign of left ventricular failure, sir.
No. Presence of S3 with tachycardia, you call it as
Mm.
S3 with tachycardia. Anybody else? Any other PG?
Delta.
Gallop.
S3 gallop.
S3 gallop.
S3 gallop. You can further qualify it. S3 gallop on left side. It can occur on the right side also. left-sided
S3.
gallop.
Left-sided gallop.
Generally, it will be S3. S4 is very unusual. Okay. Left-sided gallop. Okay. This child, you call it is having gallop, right? Okay. Right. Now, we will proceed to the next. You have some investigations and you showed some X-ray, isn't it?
X-ray.
Yes, there was one X.
Now, after clinical diagnosis, we may go for completion's sake. Would you like to read it for us for our enlightenment?
Yes, sir. It is a.
No, for want of time, you may skip technical issues.
Yes.
Right. For want of time, otherwise you are expected to mention.
Yes.
Only one thing you tell, whether it is inspiratory film or expiratory film. Why it is important is findings in expiratory film regarding the heart status may not be correct totally. Is it inspiratory or expiratory?
If it is an expiratory film, apparent false cardiomegaly might be.
No, that's why I'm asking only that technical point. Right. Now you tell about the findings.
It is an anterior posterior X-ray, sir, of the chest showing soft tissue structures and bones are.
Okay. What is normal, you may skip for want of time.
Right-sided infiltrate can be higher infiltrate is appreciable, sir, and
Right-sided?
right-sided middle zone infiltrate is appreciable, sir.
No, now we are more worried about the heart status. So you start with cardiac CLOT.
Left-sided, sir, pulmonary area pulse can be seen, sir. The aortic knuckle is prominent, sir, around that.
No, first you talk about apex.
Apex is, sir, apex. Left
Is it either cardiomegaly or not?
Yes, sir. Cardiomegaly is appreciable, sir. The CT ratio is calculated around more than 0.5, sir.
You know how to take the measurements under the guidance of Dr. Samarendra. I need not talk about it. So there is cardiomegaly. And what happened to the left border of the heart?
Left body, sir, it is appearing enlarged due to left.
No, don't say left border is enlarged. Border will not enlarge.
Yes. Border is silhouetting is not there on the left side, sir, left border, but the right sided near the
No,
upper,
we started with left. What happened to the left border?
signs of sir dilation are there, so on the left side, sir.
Dilatation?
Yes, sir. Yes,
What
like,
is that?
and on the upper aspect, sir, there's a bulge around the second pulmonary area, sir.
What is it? It is
Due to
because of
hyperdynamic flow around. Yes, sir. Yes.
no, what is the structure I want to know? See, X-ray tells you about structures. You say what it is.
Pulmonary artery, sir. Around the
Main pulmonary arterial
Main
trunk,
pulmonary
MPA. Main pulmonary arterial trunk. What happened to it?
Sir, it is appearing enlarged, so instead of dilatation.
If you don't say enlargement, you say dilated. Main pulmonary arterial trunk has dilated due to
increased hyperdynamic flows. Yes,
don't say hyperdynamic flow, increased flow through the main pulmonary artery. Whenever the flow is more, the vessels dilate. Whenever the flow is less, the vessels are likely to be a little hypoplastic. Classical example is hypoplastic vessel because of the less flow through it.
yes.
Same pulmonary artery. It can be hypoplastic in which condition? When the flow is low.
Yes. So, petrology of valve is there, sir. It
Valve strategy. So it all depends on the flow that decides the diameter of the structure. So there is increased flow, gross increase in the flow through the pulmonary artery. That's why I didn't want you to put the mild there. You may hedge towards moderate to severe rather than to mild. You can see it is classically dilated there. Okay. What else?
Right ventricular right atrial dilation and the right border is prominent, sir. Right heart border is also prominent.
So first you describe it as a radiologist. When you are reading an X-ray, you are a pediatric radiologist. Inference follows. What you are observing is first you have observed dilatation of the left main pulmonary arterial trunk. Then you say what it is due to. You say, like a pediatric radiologist, see what happened to the right border of the heart.
It is appearing prominent, sir, due to left to right side, probably, sir, due to increased flow into the right.
Due to what happened? Why it is appearing beyond the right sternal line? You say right border of the heart is there beyond the right sternal line.
Due to left to
And
right
when you
shift.
comment like this, always make it a point that there is no rotation. If
Yes.
there is rotation, you shall not comment like that. If there is no rotation, this picture is suggestive of.
Left to right shunting, sir.
No, you say what caused it?
Due to ventricular septal defect, sir. Left
No,
to-
sir. Left side, the bulge is because of the pulmonary artery which is dilated.
Yes,
So
sir.
you tell what has caused that
Right
capacity,
right
right?
right ventricle, sir.
What is the right border of the heart is formed by
Right atrium, sir. More of
right atrium. That's it.
more
That's
of
it.
right atrium and
Okay,
bliss.
the vessels above and below, just we will leave it for time being. So it is the right border of the heart is formed by right atrium. Any thing goes beyond the right sternal line, it is because of the right atrial enlargement. You cannot appreciate right ventricular dilatation that side. Where do you appreciate right ventricular dilatation?
It is more toward the posterior aspects, sir. Right ventricle.
No, right ventricle is the most anterior
Ah,
part in the heart.
Just below the sternum, sir.
Then why do you, how can you appreciate posteriorly? There is thick
Yes,
musculature.
just below the
vertical canal.
sternum, should can do.
Then how do you know whether there is dilatation of the right ventricle?
Upturned apex might be seen, sir.
That is hypertrophy, not dilatation.
Yes, sir. Shifting of
You yourself told there is shift of apex laterally.
yes, lateral.
That is right ventricular dilatation.
Yes.
So here right atrial dilatation is due to
Back pressure changes, sir. Due to
from the right ventricle.
more
It
of-
decompensated right ventricle,
Yes,
decreased compliance, more pressure in the right atrium and the right atrium getting enlarged. So with such a congestive heart failure, such a PA has such a large amount of QPQ or QS ratio is very high. You can even call it as severe septal defect. Okay. What else? That Subramania has come when you want to read the lungs.
No, sir, I just had a doubt. Can this be a mix of two shunts? Something like, say, mild VSD plus an ASD?
That's
Because you are
wonderful,
telling-
no. Yes, Dr. Subramania has a point, Dr. No, this is a point which raised by Dr. Subramania. A professor has to answer, not by a question by a professor, right? Dr. Samrendra, what's your thoughts? on
Sometimes
Dr.
they
Subramania's
do
question?
coexist. So therefore, how to diagnose them when there is both shunts? One of them, we are diagnosing moderate VSD from the logic of hemodynamics. What if there are two shunts, but physiology remains moderate, but there are two small shunts?
It may be possible, but the presentation, particularly if a large VSD is there and a small ASD, so the presentation will be quite early.
Dr.
According to
Subramania?
you, sir, the presentation depends on the quantum shunt, sum total rather than an individual lesion.
Because AV canal septal defect, mostly their presentation is quite earlier and without treatment.
Okay. Can we have isolated ASD and an isolated VSD, separate?
Separate. Possible, sir?
It's possible, no, sir. Sometimes we do miss them.
Possible.
For the attention of all the postgrad attendees, what Dr. Subramania wants to appreciate is, don't be satisfied in identifying a single lesion. What I was talking is, look for other anomalies in other systems. Dr. Subramania has gone one step ahead. It is sometimes there can be more than one abnormality in the heart that we have to be always on the lookout. That is what Dr. Subramania wants to give as a message, right? Regarding lung zones, Dr. Srijan, Dr. Subramania is an expert in pulmonology. You tell.
Right side, middle zone infiltrate is appreciated around the hilum, sir.
No, don't say infiltrates.
Patch, sir.
Patch. Floppy opacity.
Should be more specific. Clinically, what you thought it.
Pneumonia, sir.
What picture it gives radiologically.
More of a localized.
Now, non-homogeneous radio opaque shadow is seen in
Right hilar zone. Middle,
not hilar.
right middle zone around the hilum.
Right middle, not around. See, hilum is not connected with the middle zone. It is in the right
right
middle zone.
middle zone.
That's it. Okay, that is because of pneumonia. What else you are appreciating?
Beta, is that silhouetting the right cardiac border or non-silhouetting
Yes.
the right cardiac border?
For
That shadow,
mild silhouetting can be seen, so not very clearly appreciated.
isn't it? So it is likely to be posterior. Okay. Can it be lymph node or is it alveolar shadow?
Not likely to be.
When you say hilar, I will ask you this question
It's not-
only for theoretical purpose. Okay.
Not-
Not related to this case.
It is not well rounded or any specific margin.
Excellent point, isn't it? So that is likely to be a fluffy shadow due to a parenchymal disease. That's good enough for this X-ray. Do you think that radiological findings should correlate with the clinical findings? Is it necessary always or not necessary?
This case, sir, they are correlating, but as of not always.
Sometimes the X-ray can be normal
Yes,
when the patient is abnormal, and you can have normal X-ray when the patient is abnormal, or other way around also. You can have an abnormal X-ray in a normal patient also. So therefore, don't be so biased.
Yes.
Correlate again with the clinical findings, isn't it? Okay. Please continue.
No, you have not commented on the lung zones. Apart from pneumonia, anything else? Not pneumonia, apart from any non-homogeneous radio-opaque shadow, anything else you are appreciating?
The lung fields are not oligemic lung fields are visible, sir.
not
Oligemic.
No,
You
not
say-
not visible, sir. Pulmonary plethora should be typically seen, sir, because
Not oligemic. See, the X-ray is not very
Ah,
clear.
yes,
That
sir.
doesn't keep this X-ray to be lung zones to be oligemic.
Yes.
If you are seeing oligemic, that means the X-ray is not
Yes.
there.
the diagnosis is
Yes,
very
sir.
What do you expect?
Plethora.
So much of flow into the lungs. You
Plethora.
say
plethora.
plethora. That is appreciated near the hyla, isn't it?
Yes.
Yes, sir.
Right. Hyla is very much clear because the X-ray is not all that good. You are not seeing them up to the periphery in the right lower and middle zones, but left lower zone. But other areas you are able to trace the vascular markings to the periphery. So there is pulmonary plethora. Next.
Hyperinflation can also be appreciated.
Right.
Sir.
The radiological diagnosis is
Pneumonia. Sir.
no, no, see.
Right.
First,
middle
talk
zone.
about the most important thing. Pneumonia is you can treat in 7 days. Of course, it can be life-threatening, but more important, you tell first.
Yes, sir. Cardiomegaly is appreciable, sir, with dilation of the main pulmonary artery and right atrium is appreciated, sir.
Right, with pulmonary plethora and pneumonia.
Yes.
Right. Next.
Can you comment on the carinal angle?
Is not well appreciable. Sir.
So if you say right atrial enlargement, I would even ask that. Okay, not necessary. Okay, then please go ahead, no issue.
This much we have, sir.
Right, sir. I think,
No.
Professor Samarendra, your comments regarding the case and general message to the postgrads who are attending. We will wind up because of the time constraint.
Now, do you have the ECG at least?
Sir,
ECG?
actually, he has forgotten. We have
Okay, no issue.
No, he
Fine,
may
fine.
tell the findings if he
Findings.
remembers.
Left ventricular hypertrophy can be seen in later stages. Sir.
No, not can be. What you have appreciated in the ECG. That's what our question. If you remember, you tell. Otherwise, we will leave it.
Exactly, I don't.
You don't remember.
Okay, no issue.
No, leave it. Professor Samarendra, your wisdom to all of us, especially for postgraduates.
Okay. So what happens to the second sound postgraduates? It is regarding A2 and P2. Reason, can you explain?
Splitting will be.
Yeah,
Splitting
about the splitting.
increased pulmonary blood flow, the P2 will be delayed and that will cause a wide splitting, but which will change with inspiration. Not
Okay. It is wide but not fixed.
Variable split. Right. Yes, sir. I wanted you to speak about this case in general and message.
So definitely the diagnosis will be, it is a congenital heart disease. Whenever we are discussing any heart disease, first we have to tell about whether it is a congenital or acquired. So it is a congenital heart disease. If congenital, then whether it is cyanotic or acyanotic. If it is acyanotic, then what type of shunt? It is left to right, then QPQS ratio, then what is the size of the VSD? It will be moderate VSD. Which signs of pH is there or not? Even if it is not there, still then we have to mention without pH or with pH. And if CCF is not there, still then we have to mention about with or without CCF. And in sinus rhythm, because sometimes some of the heart disease may have some other problem. For example, ostium primum defect. The ECG will be something different. So sinus rhythm and also the complication, particularly we are more worried about the complication, that is the infective endocarditis. So you have to rule out infective endocarditis. So with or without infective endocarditis. And the presentation, usually they present with pneumonia and also under nutrition or malnutrition. So everything, and with signs of other vitamin deficiencies.
Dr. Srijan, one point you should have added in the clinical diagnosis. Can you recollect?
About micronutrient status.
You specify further. Okay, micronutrients specifically.
Anemia.
The child is anemic. The infant is anemic. Compared to any other disease of say respiratory or GA, when it is anemia is associated with a heart disease, especially in failure, the scenario will be more worse, isn't it? It worsens the heart failure. Okay, so you can add anemia, maybe nutritional anemia, right? Because it has direct bearing on the decompensation of a heart disease. Compared to in any other scenario, here the anemia is of specific, specifically you have to mention. Okay. Nice. Dr. Srijan, you have presented very nicely, and I congratulate you. And Professor Samrendra has mentored you very nicely. And thanks, Professor Samrendra, for sharing your knowledge and wisdom to all of us. And we had a wonderful session. And now I invite Dr. Subramania, followed by Dr. Biswajit for his comments.
Sir, I have got, let me take away the focus from the congenital heart disease for a while for those postgraduates who are watching. What is the management of community-acquired pneumonia in this patient with a pre-existing congenital heart disease? This is very interesting. And secondly, what is the type of antibiotics that one would offer? Only these are my suggestions. However, Dr. Mahapatra will take the call based on what he sees on the bedside, which I am not going to comment, but generally. See, now this child has malnutrition as well, or failure to thrive or malnutrition or nutritionally compromised. And therefore, I would not give monotherapy. And I would not be treating this child on oral amoxicillin, given that the breathing difficulties are there. Although there are studies which says that even in patients with retractions, one can give oral therapy and for short course of duration. So there are definitely debates about oral amoxicillin, which I agree. So therefore, the line of antibiotics would be intravenous antibiotics. So a combination of cephalosporin with an aminoglycoside would be the right choice, given that you cannot say only I would suspect strep pneumonia and other organisms. Please also consider gram-negative organisms in this particular patient, given that the child is malnourished as well. And just 6 kilos at around 10 months of age, this child should be protected well. And I would just go one step ahead and just give pneumococcal vaccine. I wish that that is given as a part of it. Suppose in case it is missed, one would say, because how do you protect the lungs? Actually, what is the mortality that can come out of a congenital heart disease with a shunt is always in the lungs. So that should be addressed. And sir, I will leave Mahapatra to comment on only two things, sir. I'm expecting expert comments from you on how do you manage pulmonary hypertension and when probably you would advise surgery in this patient. These are only two things that all the postgraduates will be eager to listen to you. Given, let us assume that the echocardiographic findings are consistent and
Yes.
there is a moderate pulmonary hypertension, which would
Yes.
be anyway going to come inevitably, and ECG will show some biventricular hypertrophy. Let us assume that this is expected, isn't it?
Yes,
And
sir.
hemoglobin will be somewhere around 9.7 or 9.5, which is expected.
It's
CBC
9,
will
sir.
be It will be 9 and you will see, I will tell you 14,000 or 15,000 will be the counts with some
Yes.
40, 45 polymorphs. That's what you are going to expect in most of the cases. So given that, what would be your comments as how do you, I have told you about my part of pneumonia. Sir, I would like to learn from you how do you manage pulmonary hypertension part of it and when will you do a surgery?
So particularly in this child, so definitely we are going for oxygen therapy by nasal form, and also we are giving IV antibiotic, whatever you have told, ceftriaxone with amikacin, ceftriaxone with amikacin, and diuretics, that is the furosemide we are giving,
Okay.
and also simultaneously we are counseling the patient, that is it is 7 mm, and the child is presenting to various hospitals. This is the fourth admission with mostly pneumonia and CCF also. That's why in this child, definite surgery is required, and I will, if they're taking the child for surgery, if they can afford, they can go for they can go for
Closure of the VSD.
a device closure, and if
Mhm.
they're not able to afford, then definitely pericardial patch closure.
Okay. So device closure is practiced in some places, whereas
So till now,
it
our
depends on the choice of the cardiovascular surgeon.
sir,
There are people who do large shunt closure by device also, small ones also, although there are different, I have heard from many cardiologists in different ways. There are adventurous closures and non-adventurous closures also of the VSD that the people will do.
actually, for device closure, there should be two margins, superior margin and inferior. This is the defect, and there should be two margins, superior margin and inferior, adequate, so that device closure can be done.
Okay. My message, Dr. Ramakrishna sir was asking, you people always, postgraduates draw a diagram of the heart and show the shunt and all that. Go to the cardiothoracic OT and please see the defect. You will be mesmerized to see that what dreams and imagination that you have in the brain
Yes,
versus when the surgeon opens what you see are totally different.
yes, sir.
When I went to fellows, the kind of I mean, when I was reading textbooks, what things I had in mind versus when I saw on the table, they were totally different. And please watch and live. If you can't go to a OT, at least watch on YouTube. How does a defect actually looks? Because this is very, very important. And if you understand three-dimensional view of the heart, then you are almost done as far as everything that Dr. Ramakrishna was talking. The radiation to the back, which is the base, which is not the base. You will understand them very well if you're not on a two-dimensional picture of on a paper. Versus if you really want to understand echo and ECG, plus X-ray and clinical findings, I think my message is that please go to OT and watch. If you can't, at least see it on YouTube. There are definitely, I think there are uploaded surgeries available. Please watch them once so that you will learn better. This is a simple message, but it looks very simple. But I would wish that after that you come back and read your cardiology books.
Thank you, Dr. Subramania. Dr. Bishwajit Mishra, your comments.
Good
No,
evening.
you are representing CIAP. More than the subject, I want you as a man, office bearer from CIAP, you may talk. People got a little
Thank you
reaction
so
with
much.
the subject so far.
Thank you so much, Ramakrishna sir and Dr. Subramania and Professor Samarendra. Actually, I am thankful for giving our Eastern a chance, and Dr. Samarendra and his postgraduate they did their best, and I think I wish them all the success. What message I would like to give from my clinical experience is that, as postgraduate students, sometimes when we see a pneumonia in a 1-month-old baby, so when you treat and when the child gets well, just be careful to exclude any congenital heart disease in this patient, particularly a newborn or a neonate having pneumonia or something like that. You don't miss out on a congenital heart disease. That aspect you always have in your mind. Many a times, a baby has presented with pneumonia at 1 month of age. We have treated, and we have decided, okay, it is not that very clear on the auscultation. There is a murmur, but when we do an echo, there is definitely some congenital heart disease there. So that is the message that I would like to give, that whenever you're getting somebody very early in the newborn or neonatal age, pneumonia, try to exclude congenital heart disease. And always you do perform the SpO2, you know how to exclude in the newborn the congenital heart disease. Never forget that the upper limb, lower limb SpO2 monitoring. That helps in a great way to exclude any congenital heart disease in the newborn. And thank you so much for all the faculties. I think Dr. Ramakrishna is a teacher of teachers, and Subramanya sir needs no introduction. He's a master of masters in respiratory, and he's just enchanting and all. And thank you, Professor Samrendra, and our postgraduate from AIMS Bhubaneswar. You have done a great job, and thankful to all those who have attended today. And I'm sure that Dr. Ramakrishna will also invite me in the future to have some sessions with him. It was really great knowledge acquiring from all of you, and I'm really thankful for that.
Right. Thank you, Dr.
Biswajit
Biswajit.
ji, Ramakrishna sir, allow me to just have one line.
Yeah, definitely, sir.
Biswajit ji, I totally agree with you on the point. I wanted to share my experience whenever I have seen a respiratory tract infection coexisting with a congenital heart disease. The problem is on day one, when there is a respiratory distress, when you auscultate, mind you, I have missed many murmurs, and let
Yes,
me accept
absolutely.
that point.
That
When
is what I
you
told.
when
At
you
the time
stabilize
of
the
discharge,
child, give
always
oxygen, give
yes,
latex, the next day zoom 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 murmur is heard. And the first day
yes.
where that zoom zoom was going, nobody knows. I'm sorry for telling you in that such local language, but that makes you to really feel that the next day after admission, maybe sometimes you pick up congenital heart disease, especially small shunts or moderate shunts or even the large shunts. They can be missed. It is very much possible, and don't shy away by telling that you have missed. Even in routine immunizations, DPT, etc., when the patients come, I have missed congenital heart disease when my colleagues have picked up. Gracefully, I'm accepting, and it is very much possible. And shunts are the ones which are likely to be missed. Let's not worry about them. We need to keep examining and picking them up. It does happen. One need not feel very guilty, and even dextrocardias are missed. So why only we talk about shunts? Sometimes we tend to auscultate on left side of the heart is really on the right side, but heart sounds are also heard on the left side. We just try to put a step and take it away. And when there is no other finding, then we are likely to miss. So missing is not a big thing. And please don't worry. You need not be Mr. Perfect. But the point is that revising, revisiting, and re-examining should be your culture. And then I think that's the best way forward. Sorry, Ramakrishna sir, I
Oh,
interrupted
no,
after.
why, sir? Thank you, Dr. Biswajit, for three things. First of all, on behalf of CAAP, your office bearer and vice president, you have given this wonderful module activity to all the postgraduates and pediatricians across the country. Secondly, for being with us. Thirdly, your message is very clear and loud. Whenever something occurs atypically, in a atypical age, you always suspect something is more. What is meeting your eye? It's a good message what Dr. Biswajit told. The fourth thing for which I am thankful to him is he the man who suggested name of Professor Mahapatra. Otherwise, I don't know. Thank you, sir. Dr. Biswajit.
Just,
Dr. Srinivasan, it is, yes, sir.
Dr. Srijan is second year, sir. Just second year.
Yes, yes. In second year also, he has answered well. Right.
So for the
Very
exam,
good, Srijan.
suppose you are
Srijan, I forgot to give you gold medal. Okay.
It's always taken for granted from our side.
Okay.
Being
Please
a second year resident also, he answered well. Now it is the turn of Dr. Srinivasan, Professor Srinivasan, for his comments.
Yeah, there is nothing. Of course, it has been very well discussed, and of course, it's very important that you keep open mind, and then always in any respiratory disease, you always think of possible cardiac problem, and then auscultate in a quiet room. You may be able to find out what is the cause, and well discussed. So there is nothing much more to be told by me. I was enjoying the discussion. Thank you. Of course,
Thank you.
Subramania was in his elements and he has enjoyed that comment also. And don't worry, you can always go and examine next time.
Even though Professor Srinivasan may not have much to tell, but there is a lot to learn from Professor Srinivasan. Compared to many postgraduates, he always stays in the discussion till the last minute. That one should emulate. Second thing to emulate from Professor Srinivasan is his simplicity and humbleness. Third only I put subject and academics, even though he is very knowledgeable. The first two characters are more important than subject, I believe.
Thank you,
so much,
sir.
Johnny.
Thank you. Thank you.
Right. Thank you, Professor Samrendra, and all the best, Dr. Srijan. We'll close. Dr. Samrendra, we'll close up, right?
Yeah, we'll close. Good night.
Good night,
Thank you,
all
sir.
of
Good
you.
night, all of
Good
you.
night. Good night.
All the best.
Thank you, Dr. Biswajit, for joining. Thank you.
Thank you, sir. Thank you so much. Good night, sir.
Right, sir.
Good night, all of you.
Good night.